All right, let's get started. Today's subject is community support services for mentally ill and ex-mentally ill persons. And let's welcome the administration's representatives. We have the Rehabilitation Commissioner and also representatives from the Bureau. And also I'd like to welcome the deputations for joining us today. And the arrangement for today's hearing is that everybody will have 3 minutes for your presentation, and you will have to be responsible for your own remarks, as the Electoral Powers and Privileges Ordinance will not apply to your remarks. And earlier on, because of the arson case in the MTR, there was stigmatization of the mentally ill, and there was widespread concern in the community. And in the wake of the incident, we heard from the Bureau that this is a mentally ill patient, and apparently that was the cause for the incident. Indeed, the case still has to be investigated, and in the past, very often, when there are social incidents or violent incidents, over the time, the explanation was that those were caused by the mentally ill patients or the ex-mentally ill, and that also resulted in serious stigmatization of the mentally or ex-mentally ill, and that would also deal a blow to the families and relatives concerned. So today we are here to look at the situation of the mentally ill and the ex-mentally ill, as well as their families and relatives, whether or not community support services are adequate, and as stated in the paper, whether it's the hospital authority or the support services available under the SWD, they are all shown here. So from that we can see that despite the large demand, the services might not have been adequate. So let's first listen to the deputations, because the paper basically set out the existing services that are available. So let's listen to the deputations' views, and then we'll invite the administration to respond, and then I'll open the floor to members. All right, if there are no questions, then first let's invite Mr. Choi from the DAB to speak. 3 minutes, please. Good afternoon, Chairman. I'm from the DAB. My surname is Choi. According to the WHO, we have about 450 million people in the world suffering from mental illness or dysfunctioning of the mental functions, and that would account for about 15 to 25% of the total population. And for the mentally ill is about 1 to 2%. And if we have a population of 7.4 billion, then we have over 1 million people who might be suffering from certain degree of mental illness. And for the SMI, the severe mentally ill, that might be up to hundreds of thousands of people. So people might be shocked. In fact, this is a disease that anybody might be susceptible, and therefore we have to be careful about this. And the administration has been talking about providing support, and we have to deal with our emotional problems. And in 2008, the UK has this pilot program, and the organizations have to come up with a connect and be active and keep learning and give guidelines. So these are the behaviors that would promote mental health, and many organizations have adopted that. And in 2013, the UK actually at different levels of the international community adopted this. But then in 2015, well, in Australia, they also launched this Act Belonging Commit program, promoting community concern for psychological health. And there would also be programs to promote mental health. And after 5 years of the campaign, many people found that they could do certain things to improve their mental health. When there is a heightened awareness in the community, then they would not be that resistant of the ex-mentally ill reintegrating into society. For example, in December last year, we once again revamped our community support service, and there are some 24 NGOs running integrated centers, and they would provide one-stop district-based services for the mentally ill or the ex-mentally ill. But then in the process of selecting sites for the setting up of the ICCMWs, the Integrated Community Centers for Mental Wellness, there were difficulties because the community was not that cooperative. In fact, if you look at the international trend, more importance is now attached to reintegrating into society, so that there would also be daycare and day support, so that when their situation or condition is stabilized, they can go back to the community and restart their life. And what I like to say is that there are many people suffering from a lot of stress, and we have heard stories of suicide and so on. I'm not going to go into the details of individual cases, but then what I'd like to say is, well, for the new generation in our community, we have to work harder. We have to make sure that for new infants, when they go to the maternal care homes for checkup, there should be early identification of problems. If there is any child abuse or drug problems, then we have to provide better support for these families in order to ensure that children will be able to grow up healthily, so that they would be suffering from mental illness when they grow up, or else the community will be paying a higher price in terms of support. Thank you.
Mr. Kwan Kim-man, Ms. Kwan Kim-man, greetings everyone. I would like to respond on the person who spoke just now. Now, he talked about mental health education. I'm all in agreement to that. Now, apart from that, I think we also need something else. Now, actually, I think it was mentioned before in another deposition that we have to start from primary and secondary education so that people will know more about mental health, so as to reduce discrimination and the people not accepting the mentally ill. More information, more knowledge would help oneself and also help a person in dealing with problems that may arise among the people in the surrounding. And we also want to see more community support, and we have mentioned this earlier. We do want to see that there is reference to the service provided to the elderly, such as service coupons, so that there is a community and medical service coupons available to the mentally ill. At present, there are a lot of hurdles to getting to the service for the mentally ill, and also resources are quite limited. We would want there to be more flexibility so that these persons can get to the services easier and to solve the problem of difficulty in accessing the services. And also last week at the deposition, I missed one point, and that is I should have mentioned that Chinese herbalist support, that is traditional Chinese medicine, should also be a channel for supporting the mentally ill apart from Western medicine. That is to say, to install the health of the person. All these can also help. And Mr. Ko, the director of the department, had also mentioned that traditional Chinese medicine is something that can be considered as a channel or means to support these persons. So I would think that other alternative medical and treatment means can also be explored to help the mentally ill. Now, Mr. Cheung had mentioned the carers' support. I do want to hear more voices concerning this, and I know that there are carers groups and voluntary groups are here as well. We know that the carers are under a lot of pressure, and we do want to see more services to benefit them. Mr. Chan Soo-young. Thank you. Mr. Chair, for the ex-mentally ill, reintegration into society is very important to extend their circle, and to install a sense of self-esteem is very important. There is a lot of services provided by the NGOs, and this, together with the HA mental health services, there is no referral services among them. And a lot of people are therefore lost within that kind of network. I have certain suggestions to make to the administration. First of all, there are some seriously mentally ill persons. They have execution inabilities and focus deficiency, attention deficiency, and therefore they are not able to take care of themselves and their household duties, and it has been a detriment to their well-being and their recovery. And also there is a lack of social service and community support for the mentally ill. And for the people at large, there is a lot of discrimination against and inacceptability and misconceptions about mentally ill, and it forestalls or discourages early treatment. So public education is of utmost importance. For the stable mentally ill with stable situation, we want there to be reintegration into society and also medicinal support. However, there's insufficient service. Their work is not valued, and also their salaries is very low, even if they're able to successfully find work, and there is insufficient support for their job seeking. Perhaps they can only serve at fast food stores or to fill other vacancies that are not welcomed by others, and there is no support for them to integrate into the new workspace. Now, as for the see from the statistics, the mentally ill is also part of the disabled persons of 2% of the total population, and the mentally ill is about 0.2% of the total. And how we can consider providing more funding to provide services and also daytime care, etc., is important. There is also a 24-hour hotline. Not a lot of people know about it. We hope that there can be more publicizing of this hotline, and also daycare centers should be provided, and also the carers and families of the mentally ill should also be well supported. Very often, the mentally ill would rely on friends and family to seek such support. We do want to see more resources provided to support them. Now, most of the mentally ill are not dangerous, and they are very often the most discriminated against and the weakest sector in our community. We do want to see the government providing more resources to help them, support them, and reintegrate them into society. We have Mr. Tam Wing Leung joining us. Mr. Tam Wing Leung, please. The New People's Party. Now, there are 140,000 persons who are seeking public health service for mentally ill, and this is not including those who are seeking private medical service. And there is this is very important work in caring for the mentally ill and integrating them. There is a lot of discrimination, especially when there are certain tragedies and also violent incidents happening among the community. It's very often linked up with the mentally ill. The MTR arson case early in the year, the government, apart from saying that it's not terrorist attack, very quickly, the information concerning the perpetrator was released as a mentally ill person, where he's treating receiving treatment, etc. Not only did that not protect the privacy of the person, but it also created a lot of pressure for the mentally ill. And also for the specialist medical service, there is very long queue for the mentally ill unless there is a suicidal danger. Otherwise, it can be as long as a year of waiting. And very often, the specialist doctor will have to treat over 2,000 mentally ill patients, and every time the interview consultation can only be a few minutes long, asking a few questions, and it is impossible for there to be accurate appraisal of the situation of the patient. And the next consultation can be as long as from 8 weeks to 20 weeks. And in between, there can only be so-called social support for the ongoing monitoring and support of the person. So there is a dire shortage of human resources. And also for case managers, one person may have to be dealing with 50 to 60 cases for social work, and that is highly insufficient. Frontline social service workers are under great pressure, and with 6 years of implementation of the scheme, there is no review of the resources for supporting that work. In some areas or districts, the population had risen a lot, and also the ex-mentally ill had been increased, but still there is no adding of more manpower. And so also there is no estimate of future need for mentally ill support. How many more persons will seek help, and how do we add more resources, both human and otherwise, to meeting that need? This is completely not acceptable. We hope that there will be improvements in the future. Thank you, Mr. Tam. Ms. Lau Ching-kun. The MTR arson case had attracted a lot of attention. And we see that the mentally ill, especially for the serious mentally ill, there is dire insufficient community support. And also the support scheme provided by the government needs to be improved. This new scheme is to support the mentally ill in rehabilitation and integration into society. But there's insufficient commitment, so that the case managers are highly short-handed, and that includes psychiatric nurses and also registered social workers, as well as the other supporting medical personnel. In the 2015-2016 community nurses, there were 130. For daytime psychiatric centers, there were 222 and 400 patients, and the service had been deteriorating in quality, and also the family and carer support is insufficient, so that the mentally ill persons do not get sustained and sufficient support. I'm in contact with these persons, and I see that every time they go for consultation at the hospitals, only then do they see the social worker. And after release from the hospital, they have nowhere to go to seek social service. Where they are unstable in their emotions and where they need help, it would be like applying for disabled help. Nobody is there to help them. The service is insufficient, and the carers around them are under a lot of pressure as well. That's why we see that for these integrated centers, it is all the integrated community centers for mental wellness is very limited in their resources. We want there to be a review of these mental wellness centers and also the scheme for rehabilitation of the mentally ill, so that there can be an improvement of this three-tier platform, and that is on service, district, and also government. There can be more integrated efforts to help this needy sector, so that they can be given the relevant support and sufficient support in the community. Ms. Poon Fong Ngoi of Oi Kwan Social Service. Yes, for greetings. It is said that the children are the pillars of the future, And whether this can come to pass depends on whether the society and also families provide for a good environment for growing up. I would like to know whether you know about the children of the mentally ill. A 10-year-old person in primary 4 with a primary 3 sister has a single mother. The father had left the family because the mother is mentally ill, and the single mentally ill mother has been taking care of the 2 young children, and the children urge the mother to take medicines regularly, etc. But sometimes it doesn't work. And every 2 years or so, the mother would move, and the mother is fearful of strangers. And this primary 4 son had said that there was one time they were very worried, he and his sister, because a mother took a fruit knife and left the home and did not come back all through the night because a mother was afraid that there was someone monitoring them, and she felt persecuted. The children didn't seem to be in trouble. They went to school as usual, and they were quiet, and therefore the teachers at school did not notice they had problems. I just want to point out the children of the mentally ill are under a lot of pressure, and they have their problems because they do not know how to voice their problems. There has been a lot of research outside of Hong Kong where it shows that the family members of the mentally ill is prone to also being affected and getting emotional disturbance, and there can be cross-generational mental illness because of the situation of the mentally ill person in the family not being well supported. At the Hong Kong U, there were 130 such parents, and the research was done on their underage children, and it is found that where the mentally ill parent has significantly heavy or serious problems, their underage children also have adaptive problems, and over 60% of the children have ADHD and also ill adjustment, and partly it is because the parents have very violent means of disciplining the children.
That would also affect children's progress in terms of rehabilitation. So the conclusion is that for intergenerational problems, the risk would be high, and therefore we propose that at the ICCMW we should have dedicated groups to pay attention to those families with children under the age of 15, so that there can be more support services for these families. There should be more peer and family support for them, so that for the underage children there should be progressive follow-up action in order to make sure that they would not come down with symptoms. Next, Ms. Lau. Good afternoon, Chairman and members. I'd just like to share with you the needs of the families. What we'd like to see is that there should be more clinical and psychological counseling, and there should also be more family treatment service. Because for families with such illnesses is a problem that would affect both their mental and physical health. We propose that there should be more resources put into clinical care, counseling, as well as family treatment. We would also like to see an upgrade in terms of psychiatric services by the hospitals and also counseling services, and the waiting time should also be shortened. At present, under the Integrated Community Centers for Mental Wellness, there is no clinical psychologist and family treatment service available. And then at the hospital level, there is also a severe shortage of specialists, and the waiting time can be more than 6 months, and they would also get follow-up treatment once every 3 months, and they would only get to see the doctor for just a few minutes, but then the psychiatrist would be very busy and they couldn't spare much time for the patients. So these services might not be able to help these families. And according to a family member, she said that she'd been taking care of the her ill son, but then the direction that she has taken would be somewhat contrary to the psychiatrist, and the son would be kept in between. And so despite seeking treatment and help, her son didn't manage to get a lot of help And after a while, she only managed to get a community care nurse to help her. And then afterwards, her husband came to realize what's the need of the son. And then with the community nurses' assistance, there has been a lot of change. So with a change in attitude and approach by the couple, the son's condition also improved and became stabilized. So that's a real case. So we believe that counseling service would be very important because it goes to the root of the problem. And then in the long run, that would also help reduce the relapse rate, and that would also help the ex-mentally ill to reintegrate into society, and family care would also play a very important part in supporting the ex-mentally ill, and therefore family support would also be very important. At present, for psychiatric or the psychological help, most of that would only be available in a private market, and the cost would be very high, and for most families they cannot afford it. Therefore, we hope that the administration would provide clinical care as well as counseling service so that there can be clinical psychological counseling service available. Thank you. Thank you. Next, from the Coalition on Hong Kong's Mental Health, Mr. Wong. Thank you, Chairman. I'd like to share with you some personal experiences about case manager, because according to what I know, at present, the ratio is 1:40 to 1:60 in Hong Kong, but then in overseas countries is 1:20 to 1:29. So in terms of the caseload, Hong Kong's caseload is very heavy. And I can also see that the service scope would be very limited because they could only care for the severe mental illness, that is the SMI, for example, schizophrenia and also bipolar disorder and so on. And for those with other problems, who would be there to help them? I therefore hope that in the future the scope can be widened. And then, it's been 1.5 years since I started to see the case manager. The case manager has been very helpful. For example, he or she would be looking at my latest condition, and she would spend half an hour with me, and she would explore different issues with me, including mental health and so on. And then before I see the doctor again for follow-up consultation, the psychiatrist would be able to make assessment more readily and accurately. So I hope that there can be more manpower for case management, so that more people can be supported. Now, referring to our own coalition, that is my organization. We have been offering mutual assistance to one another. But then we do not have enough resources, because what we are now able to do is that we can only have some staff to help us with the day-to-day work. But then for more in-depth work, for example, networking and so on, they simply are not able to do it because they are not social workers. And they do not have the kind of networks that social workers normally have. Therefore, we hope that we can have more resources in order to do a bit more. And also, we should have peer supporters so that there is a role model for them to follow as to how they can be resilient in adversities, so that they would be prepared to go back into society. All right, thank you, Mr. Wong. Next, Ms. Chen Lai Lai. She's from a family support group. Thank you. I'm from the Baptist hospital, and I hope that there can be more halfway house service, because a number of years ago my daughter was suffering from this mental disorder, and she stayed in a halfway house, and there were people or staff to monitor her taking of the medication, and it helped. But then shortly after her discharge, she refused to take the medication, and she said that the doctor allowed me to leave, and therefore I'm well again, and therefore I do not need to take the medication. And the labeling, from the labeling you can see that this drug is poison, and therefore why should I bother to take the medication? And she began to be very upset about me, and as a result of that, my relationship with her turned sour, and that would also affect our daily life. Fortunately, the social worker came in, and after waiting for 9 months, she managed to go into a halfway house. So instead of being kept in within the 4 walls and struggle with her all the time, we managed to get some breathing space. And then after staying there for 2 or 3 weeks, she would be told by the professional nurses and staff there, so that she would acquire a more healthy lifestyle, and I would also be trained at the same time. So was complementary work done that would also reduce the frustration that we would feel. And after listening to my story, another family member said that well, her son would often talk about suicidal thoughts, and as a result of that, she could only spend the whole time with him. And then even if he goes out, she would have to accompany him, because she's concerned that he might be doing something harmful to himself, and she never thought of taking him to the A&E department or seeking immediate help. So if her son could have stayed in the halfway house so that he would receive professional care and counseling, then she would have more time to acquire communication skills, and also how she can deal with crisis situations. And some family members also said that because their family members were suffering the illness and they needed to be hospitalized, or they might need to receive surgeries, but then as they drag their feet, they were very concerned that the patient would not be taken care of in families. That's why such services would help the carers, so that they would get some breathing space within a short period of time. And I'd like to stress that the coalition's request is that the administration should set up more halfway house service for the mentally ill. Next, Ms. Li Po Chan. Thank you. Well, family members are most concerned that when their family members fall ill, there would be better support for them. At present, well, community services and hospital services do provide follow-up service, but then the SWD or the HA still do not collaborate very closely, so that they are not able to provide a one-stop referral service. Well, taking my family as an example, all right, he or she goes to the hospital once or twice a year, but then there is no referral service, and as a result of that, for the ex-mentally ill, when they are annoyed, there is nowhere to turn for help. And for family members, they would also be under a lot of stress. Well, after the mentally ill are discharged, when they need to go back to the outpatient service, if there is one-stop service, in other words, from the hospital to the community, if there are referral services mechanism available, then in fact you do not need to increase the resources. All you need to do is to ensure that there would be more specific and effective implementation mechanism for the referrals from hospitals to outpatient clinics, so that the families and the patients would be getting better support services. At the same time, well, family members are also aging. I think this is something that we need to pay attention to. Well, according to the SWD's report, for those carers who are over 21, that would account for some 34.3% of the total number of carers, and therefore we need to come up with a long-term service model. We need to provide better support for the family members. In particular, for the weak and frail, there should also be residential care for them. We urge the HA and the SWD to implement these plans as soon as possible. There should be better case management and also referral of borderline cases, so that in the longer term, there can be better rehabilitation management arrangements. Thank you, Ms. Lee. Next, Mr. Law Kam Chun from the Hong Kong Mental Health Family Members Association. Well, in the review report, it says that the review committee proposes that there should be better review of community service in different areas so that for those with mental health needs and also their carers, they can get more comprehensive support. We fully support that. But then, regrettably, if you look at the entire review report, there is no mention of how the policies can be implemented. And in order to implement the policy, we suggest that the government should come up with a peer support program. That's the pilot project on peer support service. Well, the Baptist Hospital has already introduced this pilot project on peer support service, and starting from the second half of last year, we actually introduced courses to provide training for the peer supporters. And for the first batch of peer supporters or ambassadors, they have already started to work. In the review report, it also says that under the case management program, there should also be more peer support. And in fact, in this month, there was a briefing session, and one of the items to be done under the project is to regularize such peer support service. It shows that the government has seen that it's very important that there should be peer support for the mentally ill, because the peer supporters are closest to the patients, and they would be there with the patients all the time, and therefore they should be given more importance and support. So we suggest that more resources should be put into that, so that carers, peer supporters service should be set up, so that there would be more systematic support for them, and they could also be given more training, so that they would know how to get along with the patients. That would be more effective. Moreover, with these peer supporters, if they can work together with the family members and carers, if they can share their experience with them, that would also enable them, as well as the mentally ill, to have more effective support. So in the community level, if we can introduce that, that would be good.
There is a very big role to play there. Thank you, Mr. Law Kam Chun. Ms. Lam Sin Man. Greetings, everyone. We hope that there will be reconsideration as to why our health and medical system is insufficient in terms of providing doctors to take care of the mentally ill. And this is has to do with bringing in overseas trained psychiatric medical personnel and doctors to Hong Kong so that they can have 2-year contracts or longer term contracts, or say 3-year contracts for them to provide service in Hong Kong, so as to supplement the shortfall of psychiatric medical personnel and also psychiatrists in Hong Kong, whether it is clinical psychologists, case managers, or social workers, etc. They are all short-handed. And that is the reason why there is, even though there is night service, it is insufficiently staffed. Even there are insufficient doctors and there are insufficient pharmacists. How can there be night service provided then? One department should be coordinating all the efforts rather than to kick around the service like a ball among the departments, so that there is a lack of coordination. That must not be. And also, I'm in support of traditional Chinese medicine to be used in conjunction with Western medicine to help the mentally disabled. And in fact, overseas experience had proven that traditional Chinese medicine can help with pain alleviation and other symptoms. So this route should be explored so that the ex-mentally ill can be given more support. And we also sincerely hope that the night service can be reopened so that the ex-mentally ill need not worry that they will not be able to get leave or be labeled because they need to go for treatment in the daytime. They can actually go in the nighttime. And also, the government should provide for service so that ex-mentally ill can have service and facilities within the work environment so that we can quickly reintegrate into our workplace. At the same time, these case managers can also help the ex-mentally ill to help with communication between these persons and their colleagues. Of course, this will take more than a week or even two, but it will have to be, this kind of support will have to be done according to the progress of the ex-mentally ill and his performance in the workplace. It will have to be long-term. It's like the helper that is hired at $5,000 per month to help those in wheelchairs. Likewise, there should be similar service for the ex-mentally ill. If they have a job, their self-esteem will improve. Yes, the Concerned Group for Rights of Mentally Ill, Ms. Pan Ching Lam. Yes, Mr. Chair, we would want there to be private public coordination where the public hospitals can refer cases to the private practice. Where there are stable cases, the private doctors can charge a lower fee for treating these cases with the support of the government. Now, for the clinics, there are but 2 clinics which provide the kind of service for the mentally ill. We hope that this service can be extended to the more serious mentally ill. This is for mood disorders, clinics for dealing with mood disorders, etc. We hope that it can be extended to the more seriously ill. Now, as for job availability, we hope that the Labor Department can refer positions and jobs to those mentally ill or ex-mentally ill who have better educational levels or attainments. Now, and also for the private sector, it is actually very expensive, a few $100s for a few days of medicine. It's too expensive. We hope that there is more subsidy in that regard. Ms. Yun Suk Yan. Yes, we're talking about today in this meeting community support services for the mentally ill and ex-mentally ill persons. Now, there are 2 sources, the ICCMW under the Social Services Department and also the HA. These are the 2 sources of services. But these services are highly insufficient to the tune that for public hospitals, it is 240,000 patients, and serious cases are over 49,000 cases. But on the other hand, it is but 30,000 that is provided by the HA and the Social Welfare Department. This is highly insufficient in terms of staff to patient, and we have been talking about this for many, many years. Training the doctors, nurses, and other paramedical staff. It's been many years. If the resources had been put in, the training done, in fact, we could have alleviated the situation by now. But we do not see that there is a timetable. We do not see that there is any execution in this direction. We don't see that there is any estimate and planning in providing more service. And the HA, where there are cases which have not been labeled as serious cases, these persons nevertheless do need help. And if the help is not given on a timely basis, they may well become serious cases. And even though there is the peer support scheme, and this will be regularized as a service, but really we're talking about ICCM of 50, and 10 of these peer support schemes, it is highly insufficient. In peer support schemes, we need to expand the development significantly and fast. And this is something that is good in terms of a direction for planning and execution. I hope that the government will step up with the planning because the service far falls short of demand. Now, serious mentally ill is these cases are identified by the HA, but in the community, we do see cases that are serious among those who are living by themselves and those who are seriously mentally ill. They need a lot of household support because of the illness, because of side effects of the medicine, because of their mobility, their self-care abilities, cooking for themselves, etc. All these they need help with. Now, these are not prioritized as cases for getting help. If I may speak some more, even though my time is up. For ICCMWs, they have also identified that there are communities which need more help, but they are not able to get more resources, and they need to get to some of the more hidden cases of the mentally ill. So we need that kind of resources and help quickly. Mr. Chung Kin Chiu. Now, we are talking about community services for the mentally ill and ex-mentally ill persons. And here we particularly want to say that the report is not able to respond to the need of the young and the youth of Hong Kong in their needs. The EC team, ICCMW, are responsible for these providing these services, and we see huge gaps. A lot of students and parents are afraid of being labeled by the school, and they fear being found out by the school and the social workers. And when these cases come to light, they're already very serious. We want to see early intervention for students and for the youth. Those who are in need, they do not know where to go to seek mental illness service, and it is a very passive situation. The HA hospital services are highly understaffed. If these are not suicidal cases or serious mentally ill cases, it would take 2 years for there to be the first consultation with a psychiatrist. For Kwun Tong and Tuen Mun, these areas which have more of these cases, it is even more serious. And it is $1,500 per session for going to private doctors, which is very hefty. And NGOs, they provide some services, but for private doctors, these NGOs can only sponsor 10 times of consultation, clearly insufficient. And for the regular cases, it takes at least half a year of consultation before there can be any effect at all. For the NGOs providing services, because they are not regularized services, therefore they can only extend their help in application to funding to the different funds in providing their operation. And very often this can only sustain them for 2 years, at the most 3. In the long term, they need more resources. For the health department and the schools, it is highly insufficient in identifying, supporting the young with mental illness. According to WHO, 10 to 20% of children and youth may have mental health situation. And we may be looking at a gap of 40,000 cases, especially for those school children who are afraid of labeling. They will hide themselves all the more. In the schools, perhaps the schemes can help them. Well, even though it says that these schemes are seeking out these mentally health children, but all the more the children and school students hide themselves. At the end of the day, it can only show that the scheme or something had been done, but it is not effective at all. We want to set up specialist teams in providing this service, which is in great shortfall. We would want to set up these teams for clinical psychologists, psychiatrists, and social workers so that these teams can go into the community to seek out the students and the parents. While they get the service, they also avoid being labeled. Hong Kong Social Service Association Lai Tik Chi. Mr. Chairman, for the community support services for mentally ill, we want to see long-term planning. In the report that came out from the government in April, it did not address the gap between support and demand, and there are no clear planning for adult mentally ill support. There is no social support recommendations, and also the self-help organizations and groups. There is no support for them in the long run. In the next 5 to 10 years, in providing for targets for the servicing of mentally ill, there is no recommendations. We welcome the report in setting up a regularized consultation group. We want there to be a high-ranking consultation group that would put into implementation education, housing, social welfare, and labor services for the mentally ill, and to support their carers and also the family in the long term, and to increase participation of these persons. The HA, the Social Welfare Department, had set up these working groups to set up the framework and to set up the ICCMWs, and also the community centers. We would want to see a rational carer to patient or medical person to patient ratio, and also better appraisal of the need of the families and carers. We want there to be more, these to be better staffed, and also to extend more community service. As for job seeking, unemployment is 2.4 times more than the average people. And for the Labor Department, disabled persons, we want there to be emotional and also psychological service and support for them.
But then they would also need continuous support. For example, their employees would have to be contacted on a regular basis. We hope that the administration would review the effectiveness of this program, and there should also be more comprehensive support. Next is about the aging population. Well, in 2011 and 2012 and 2015 and 16, we received data from the ICCMW, and apparently the number has gone up very substantially, and the administration needs to review that so that for the mentally ill, there should be better support for them. Next is about public education. In terms of adult service, in identifying location for the rehabilitation units, there has been a lot of resistance, and therefore more public education needs to be conducted, and there should also be bigger community involvement. For example, there should, in recent years, they've already introduced peer support service. Well, that would also play a very important role in public education. We hope that more training can be provided, and the number of peer supporters should also be increased so that they can play a bigger role in this. Thank you. Thank you. Next, Mr. Y. 3 minutes, please. Well, please listen to this tape recording. I often feel that this is very important. But then the administration has not taken this up and discussed with us. So would they be discussing that with us? On the part of the administration, well, Assistant Director, do you have any views? Well, thank you, Chairman. Thank you for the question. Well, as the Chair just said, the administration will be discussing that at the next meeting. There will be 2 items on the agenda. With regard to the proposal by the Honourable Member just now, with regard to employment service, well, when we look at those who have sustained injury at work, we would try to find out how the worker has sustained injury and whether or not that might have resulted in mental problems, and when necessary, assessment would also be conducted so that compensation would be awarded. And on the part of the department, we would be paying attention to such cases, and we will provide assistance in dealing with such cases. And through publicity and education, we would also provide more information to the employers and employees as to how compensation should be calculated if there's injury or mental problems with regard to the injured workers. So are you happy with the answer by the administration? I can understand it. Maybe I have to find out more, because recently I understand that, well, in overseas countries, there are cases involving some short-term work, and yet there might be lifelong emotional harm, and yet the employer might not have provided enough support, and as a result, the consequence might be serious. I understand that there are such cases, and they're really very sad cases. All right, that's the meeting held by the Manpower Panel in 2014 on occupational safety. And recently, we've also been talking about occupational safety, and only those working at the Hong Kong-Macau-Zhuhai Bridge would be allowed to speak. So in Hong Kong, there are workers who feel very annoyed, and yet they are not able to voice their concerns. And the reason why I have to use this pseudonym, that's because well, I have to go to the North Hospital for follow-up consultation, and many people there are subject to a lot of stress, and they are suffering from mental problems. So the reason why I've been late today, I'll be giving you a book later. Well, that's from the Caritas North District, and if they are trying to apply for a venue to use, and only a week beforehand they were told that the venue would not be available. All right, they're going to build a purpose-built building. So I hope that one story can be set aside for them to use. Next, Ms. Tam Yok Yi from a community network. All right, we have heard a dozen or so speakers who spoke about their situation, and I am from a self-help group for the ex-mentally ill, and I'm also an ex-mentally ill, so I can use myself as a very representative story of the ex-mentally ill. And today, what I'd like to see is for the administration to restore or reintroduce the night consultation service. That's very important to many patients. Well, I'm sharing with you what really happened to me. This is a real life story. All right, I've been ill for some time, for more than 10 years now. And during the time I've been working, and then at around year 2000, I was working at the airport. I was working as a management staff, and I needed to go back to the Kowloon Hospital for follow-up consultation, because I didn't want to disclose my illness, and therefore I would not be using my follow-up consultation card. And in advance, I would be sending an email to my expert boss, and I would be telling him that I needed to take a few hours off in order to see the doctor, and then afterwards I would ask the doctor to give me a certificate to certify that I attended the clinic. Then I'm sure you would know that they would have a certificate printed out by the computer, and it would set out that I was seeking consultation at the psychiatric service. And then I asked them to manually write out that slip, and as it's written manually, and the doctor would just say that well, she came back for follow-up consultation, and I would give that slip to the to my expert boss, and he did ask me what was my illness, and I told him that this is a privacy matter, and I was not prepared to disclose that. So I insisted on not disclosing that. So every time I did show him an attendance slip certifying that I attended the clinic. And then he also asked me if I could seek consultation in the after hours. But then I told him that I might not be able to go back for follow-up consultation during office hours. And during that time, I also tried to seek private psychiatrist consultation. But then, as you know, the consultation fee would be quite high. So it can be up to several $1,000s or even up to $10,000. So because of the high cost, I chose to stay in the public sector for consultation. But then as times change, because of the SARS outbreak, I was one of the first to be laid off. Yes, they said that that's for better cost efficiency. But then I'd been working there for 4 years, and I was also considered one of the more outstanding staff. And they said that they needed to restructure the company, and I was laid off. And I couldn't even go back to my office to clear up my stuff. And my secretary did the job for me, and I was escorted out of the airport by the security staff. I knew very well that that was mainly because of my condition. Well, because the management might have been aware of that, and that's why they laid me off. And I thought that was discrimination, and that's discrimination against those who were mentally ill. And as I said, well, the mentally ill had one of the lowest employment rates, so they had the highest unemployment rate. Well, in fact, for most of us, well, we would very much like to stay in our jobs. So if I were dismissed simply because I was suffering from mental illness, then I would not have the chance to reintegrate in society despite my hard work. So you can see how serious discrimination is now. All right, thank you. All right, we have seen coverage of your story in the press, so thank you for sharing your story with us. Next, Ms. Chen Suk Fan. Thank you, Chairman. I'd like to share with you the request by the family members. So there should be more acute support service for the family members, because we also have an aging problem with the family members, and while they age, they also have their own problems, and in some cases they might also have to be hospitalized, and they might not be able to take care of the ex-mentally ill. And for the ex-mentally ill, when they want to reintegrate into society, very often the load would be on their family members. And if you look at the report, over half of the carers, in fact, if you look at the number of hours that they spend, you're talking about over 10 hours a day. So you can see how stressful it's like for family carers. So we're working with some family members in the resource centers, and we have made reference to the acute support service available in the UK. And they hope that in Hong Kong, we can also have this emergency card in Hong Kong. So we have to establish this database for carers. So it's like the emergency call, so that where carers have illnesses, or if they have accidents and so on, is there any network where they can contact, or they can also make it known about their needs, so that there can be a 24-hour hotline set up, so that for healthcare workers and also police, well, as soon as they can identify who this person is, then they would immediately know his or her needs, so that that database can immediately be triggered in order to provide support for the ex-mentally ill. And with the 24-hour hotline setup, that can also be used for consultation purpose, so that when family members feel or face with a crisis situation, then they can be given better support. For example, we have an elderly family member who is a carer, and on one occasion he passed out and he was sent to the hospital, and the doctor suggested that he needed to have an operation urgently. But then he had a child who's mentally ill, and he was so frustrated or stressed that he asked to go out or asked to be discharged immediately. He refused to have the operation. Fortunately, he managed to contact the support group, and the son's doctor was contacted, and some supporters were contacted, and as a result of that, nothing serious happened afterwards. So we can see that if we have this emergency card service, then where there is an ex-mentally ill, if there is no carer available or around, then the network can be triggered so that the family member or carer does not have to be so worried, and then he can be reassured that he can go into the he can go in for a surgery or for other emergency treatment. All right, thank you, Ms. Chen. Thank you for so many deputations who have come to the meeting to share with us their views. Okay, we have over 200,000 mental patients and ex-mentally ill. That's the statistics provided by the hospital authority. But then if you look at the number of beds available, we only have about 3,000. In other words, overwhelming majority of the patients are staying in the community, and we can see that the current level of care is far from adequate. We've been talking about night service for many years, and yet it's not available. And also for those who have recovered and they need to reintegrate into society, and yet there is no service available. And then for the ICCMWs, it's been 6 years since its introduction, and there's been no review. And then for the peer support service, we have rolled that out, and yet it's seriously inadequate. And then for the mutual help group, they are helping one another, and yet there is no external support. And then for those families who have adult patients or underage patients, the support is also very inadequate. So thanks to the institution that has been taking care of them, they have conducted studies. They show that the service is not adequate. And in the community level and also at the HA, we also have services available, but then we have about 50,000 who are SMI, and yet the system is only serving about 15,000. And then for the community case management service, what's the caseload? I think they are also having a hard time. And then for the waiting time, we've been talking about that for years, and also for the inadequate manpower of doctors. So whether it's assessment and follow-up consultation, is also very inadequate. And we talk about medical social collaboration by the time when the patients are discharged. Should there be a referral system? And also, what about the two case management mechanisms? How do they interface? And also for residential care. So by the time when they are discharged from hospitals, and of course they have halfway houses, and yet they have to wait for a long time.
For over half a year at least. And also the assisted or temporary halfway houses or living quarters, it's been asked whether that can be provided. And also, all that I have said just now, we ask whether there is a service supply planning, and what is the estimate of the demand, and also where there is early site identification and reserving the sites for such future services to be provided, and also the carer support. I mean, Oi Kwan, the group had also mentioned issues that they have seen, and they have quoted overseas experience as well. We would like to know whether Mr. Leung would have any, and the administration will have any response. Well, we have heard the deputations with a very valuable opinions. I have 5 areas that I would want to, that I have grouped the opinions on, and I would want to make responses on that. And in particular, I will be responding from the SWD and concerning the support for the mentally ill, it comes under a few areas. First of all, in terms of social workers and service, and also the ICCMWs, and also family resources centers, and also the social welfare department provide for rehabilitation service and day community centers. Now, the deputations have talked about staffing, manpower at ICCMW. From 2010, 2012, since it set up, from its $160 million, it's an increase to $310 million, which is a 100% increase in terms of funding. As for manpower, if we look at the staffing, social workers had increased from 8.5 social workers per team to 18 social workers per team for 2017 and 18. So that's another 100% increase as well, even though we know that for rehabilitation of the mentally ill, the demand is very heavy indeed. Now, since the setup of these ICCMWs 6-7 years ago, and having referred to its history, every year we were able to get additional resources. Perhaps you feel that it is still insufficient. Well, Mr. Chair, we will continue to try our best to get more resources. As for staffing for ICCMW, the specialists include social workers, nurses, and also occupational therapists. I heard deputation saying that for clinical psychologists, should this also be in the specialist team? Well, the SWD is undergoing a comprehensive review of the ICCMWs. We will be following up with this. We hear the views voiced today. Mr. Leung, can you talk about the review? Its timetable and its direction, please. Yes, I will be talking about that. Yes, indeed, Mr. Chair. Second point is about peer support. This concept at the NGO level had been introduced a couple of years ago, and the response had been very positive. And therefore, they have talked to the SWD and the Labor Department. And you remember that we have consulted the panel at the LegCo, and we were very fortunate to have had the support of the panel of the LegCo. And in March of last year, we have come up with a pilot scheme for peer support. And under this scheme, we have provided 32 full-time peers, and these are full-time jobs and full-time positions. And after a year plus of this scheme, we have just received the approval of the LegCo. We have additional resources to, in the coming budgetary year, we will regularize this peer support pilot scheme. And the information I've just got on hand is that by the end of April of this year, the NGOs participating in this scheme had altogether hired 50 full-time or part-time peer supporters, and they are under the employment of these NGOs, and they're providing this kind of peer support service. Looking at the evaluation, we see something very positive, and that is these peer supporters, because they are themselves, they have been they've had this experience, and therefore they're able to share with the mentally ill about their experience taking medication, side effects in the short term, but long term it will be good for the sufferers, and we believe that this is very good support from the peers. And also for those who have recovered, we would want the NGOs employing them to provide training for their future employment, so that in the future, when they leave the position as peer supporters, we'll be happy to see that they be integrated into the open job market. After we regularize this service in the future, we can perhaps consider extending this service if the reception is indeed good. A third area, which had been voiced by the deputations, and that is in training for work positions. We have 3 areas: subsisted or assisted employment, and the second area is comprehensive rehabilitation work positions, and of course sheltered workshops. And we have over 10,000 of such positions under these 3 schemes. And we will be, in terms of the waiting time, yes, there is room for further improvement, and therefore in the 5-10 years coming, we hope to be able to increase the positions from 5,000, which is the present figure, to add 2,000 in the next 5 to 10 years. As for the source of such positions, there is a SWD support for the with the seed money supporting these enhancing employment of people of disability by the Small Enterprises Project. And at present, this scheme had already been given a funding of over 100 million, and we see that there are 800 plus working positions which have been created for the disabled, and of that 40% are for the mentally recovered persons. Mr. Chair, you also know that the Legislature had approved in this budgetary year another $100 million for this particular scheme, and it will be injected in this budgetary year. And in that scenario, we should be able to provide another 800 working positions for the disabled. And I also heard that the Labour Department last year had come up with a pilot scheme for the for mental health and a mental health support pilot scheme. And if this is indeed effective, proven to be effective, we'll continue with this effort. And the fourth area is concerning support for carers, and in particular for carers who are aging themselves. And on this, last year, we have come up with a subsidy scheme for carers, providing financial support to the tune of $2,000 per month for the carers of the mentally disabled. And this is a pilot scheme, and therefore very few benefit from it. After this period, there will be a very timely review of this to see how we can extend it. As for halfway houses and temporary housing, the SWD does provide for it, but we agree that it is insufficient in terms of spaces. And so we will, under ICCMW review, we will also be looking at this. Lastly, about public education, the government believes that this is something that has to be done in the long term, and the consultation committee, every year we, together with the NGOs providing support to the mentally ill persons, we periodically provide for education exercises to the public. And at the ICCMWs, there is one part of the work which is to provide public education and information to the public towards this end. And we heard just now that these ICCMWs, the permanent siting of these centers is an issue. I would want to take this opportunity to report to the chairman and to all those coming to the meeting that there is progress. The 24 ICCMWs there are 15 of them which already have permanent sites, and there is one in the fourth quarter of this year will also commence service, and there are 2 in the next 2 to 3 years. They will also commence service. So by then, there will be 75% of these centers which will have permanent sites. There are 6 more remaining, 2 of which are already there are suitable sites identified for 2 of them, and there will be certain refurbishment works to be carried out, and they will commence works soon. And there is one which will need district public consultation. And then for the rest of it, the 4 remaining centers, we believe that there are certain government services centers which can house them. We are doing internal work and consultation there. At the same time, the government is providing rental support and subsidies so that they can rent private sites and locations. Now, Mr. Chair, concerning the work of the working committee, as I have mentioned just now, for strengthening frontline specialist training and also clinical supervision and guidance in these areas, perhaps we can add more clinical psychologists. That opinion had been raised, and we are looking into it. And there are certain work, within the review of the ICCMW, where we find it mature, we will be introducing some additional services. I've mentioned some of them, one of which is the regularization of peer support scheme, and another is manpower. We also understand that the work pressure is very heavy, and therefore in the budget this year, we will also add manpower, 24 social workers and 72 welfare workers. And after this, when the resources and the funding comes on hand, we will be putting these positions into place. And by so doing, we'll be completing our work for this year.
Thank you, Chairman. Thank you for the comments made by the deputations. Well, with regard to the review committee's work during the past 3 years, most of the issues have been discussed. In simple terms, when we discuss the issues with regard to the existing services, basically we believe that they are available, but then the concern is about the quantity. So despite the fact that during the past 3 years, every year, we've been giving more funding to the HA, but then the demand seemed to outpace the level of growth in terms of resources. So what we are indeed facing is a very big challenge in terms of the shortage of doctors. We are trying our best to provide as much service as possible, but then I hope you'd understand that other than increasing the quantity of service, we should also work on the modus operandi as to how we provide the service, so that we are making use of non-doctor staff and also for community psychiatric nurses, so that for those who are mentally disturbed, we hope to be able to help them as quickly as possible. So in the review, we also talk about public-private collaboration. All right, in the public sector, if we have a shortage of staff, then what about relying or referring the service to the private sector? That might be a good way out. We understand where the problem is, and you might have come up with different ways of resolving the problem. So the next stage is for us to follow up on those, and we should also set up a platform so that all the stakeholders can be involved. So that's what we're going to do. We'll be setting up a platform so that all the stakeholders, including the family members, the ex-mentally ill, they can all take part. So we would like to set up that committee as soon as possible. And as you have heard, we would like to have better medical-social collaboration. In fact, in the course of our review, we have been talking about that. As you know, the HA and the SWD have already come up with an overriding framework so that there can be more intensive collaboration. I believe that with that platform set up, that would help. So I think I'll pause here and then I'll listen to your views. And we have two doctors here, so if you need more details, I'm sure they'll be able to provide more details. I think more than one speaker has talked about night consultation service. So we've been talking about that for years. So what's your response? Okay, I'll say a few words and then I'll defer to my specialist colleague. Well, in the review, when we met with the stakeholders, or last week, we also met with them, and many people talk about the need or demand for night consultation service. Well, the reason why we are not yet able to provide that service is, I hope you would understand, because in terms of manpower, we do have our own difficulties. That's why, in terms of deployment of our resources, we have to set priorities. That's why, for the time being, we are not able to do that. But then we do expect that once we have that standing committee set up, I'm sure that issue will be brought up again. Yes, we do have difficulties deploying our doctors, but then we have already increased the quota for, or the number of places for medical school. Well, last year we had 320, and this year we are going to have 400. In other words, starting from this year, we're going to have 100 more places and 100 more graduates. I hope that would help relieve the manpower problem. So by the time when we have more manpower available, I hope to be able to revisit that issue again. I'll defer to my colleague from the HA, Dr. Tang. Yes. At the coordinating committee at the HA, we have been discussing the feasibility for a long time, but then unfortunately, because we do have a severe shortage of manpower, we have not been able to do it. We still have many vacancies not filled, and during daytime, if psychiatrists are already working very hard, then we cannot expect them to be able to work overtime for the night service. And if we only rely on specialists who work at the night service, well, that would not be good, because every time when the patient comes, he'll be seeing a different doctor, and that would not be good for the patients. So we will have to think very carefully about how the manpower should be deployed. We hope that in the coming years, when we have better manpower resources, we would be able to do a bit more. We also have some relief measures to help those who have to go to work during the daytime. For example, for those who need to have injections, then we can arrange for them to have the injection during weekends or holidays. And if they do not need to have the attendance slip, we can only say that they've come to the Eastern Hospital for follow-up consultation, and there is no need to print out the words psychiatric department. So when you show or present the attendance slip, you don't have to disclose that you have been receiving treatment from the psychiatric department. Dr. Tang, Ms. Tam already shared her real-life story. So the thing is, you've already crossed out or taken away the words psychiatric service, and her employer still suspected that she was mentally ill, and as a result of that, she was dismissed. All right, we've been talking about the night service for a long time, and the manpower problem has been with you for years. So is it that nothing can be done about it? Is it not possible for you to rearrange the working hours of the psychiatrists so that they would be working shorter hours during the daytime and then they can be redeployed for the night service. Well, even if you try to do that, it doesn't necessarily mean that you'll be able to redeploy them to the night service, because once you have the outpatient service, the manpower that would be needed would be rather substantial, because once a doctor attends the night clinic, then you cannot expect him to be able to go back to work the next day, because he might also need to attend to the inpatients and also other kinds of work. I do understand what the lady just said, so we'd go back to look at how we can do our best in terms of the night service. Yes, Ms. Lam, we'll arrange for you to respond again. So first, the floor will have to be open to our members. So 3 would like to speak. First, Siu Ka-chun, and then Mr. Leung Yiu-chung, and then Leung Kwok-hong. Okay, thank you, Chairman. I'm grateful to the deputations for coming to share with us their experience. And once again, I'd also like to thank the government's representative, because the fact that they are able to exchange their views is already a good start. Yes, different deputations have put up their requests for different services, for example, night service and so on. I think the administration's response has been a lot more concrete this time. I think this is good, at least to me. Well, for me, who has been a member of this council for 7 months, I think this is one of the most concrete responses that the administration has ever given. Okay, in the report, you talk about the situation in different places. They have different programs for the mentally ill. All right, in Australia, they have this service available. I think Australia is amongst one of the best worldwide. The UK used to be very good, but then they have cut their budget in recent years, and as a result, they have superseded by Australia. But then you never talk about test-based service that has been provided in Australia. All right, this is funded by the state government, and then is tailor-made for the young people. And they have seen that there is this need by the young people in terms of mental health, and they provide this nationwide service. And the scope of service is something that we should pay attention to, because what they are concerned about is not very narrowly defined. It's not just about mental illness. It's about mental health, physical health, and also alcoholism and other support. First, on mental health, they would also cover youth bullying and also separation, sexual orientation, and self-destruction, and so on. And there is also a figure that I'd like to inquire with you, because they also said that many young people, about a quarter of those from 12 to 25, if you look at the mortality, the death cases of this group of people, a quarter of young people have mental disorder. And if you look at youth deaths, 3/4 die of suicide, and some 75% of the mental health problems came up before age 25. So that might have been the situation in Australia. I'm not trying to compare that with the situation in Hong Kong. But what does it say? If you look at those figures, if you look at the classification and statistics, they are very detailed. And then in Hong Kong, well, you spent 4 years on the review. I believe that you must have had a lot of data. And I'm sure in the profession, and those who are concerned about the phenomenon, they would also like to look at the details. It's not just confined to what is set out in your report, because if you look at the report, when it comes to the young group, so for the 40,000 people who are mentally disturbed, in particular for those who are suffering from SMI, do you have any age breakdown? How many of them are under 20? And we've been saying that when it comes to mental health service, we have to have more detailed breakdowns. Do we have service specifically for the young people? So that's the first part of my question. So I think I'll pause here. Okay, Mr. Sun. Thank you, Chairman. Thank you, Deputy Chairman, for raising this issue. With regard to headspace in Australia, we do have some understanding of this. In fact, during the review, the professor responsible for headspace came to Hong Kong, and he also sat down and discussed with us. And other than that, I understand that in Australia there are at least 2 or even 3 professors who also came to us and discussed with us at a seminar. Well, some discussed with us at the committee, and some also talked to us through Hong Kong Youth Professor. And I was also involved in those talks. So indeed, for the headspace in Australia, they were one of the forerunners, because what they are talking about is no longer just confined to treatment. The headspace treatment seems like a very fun area, so there would be no healthcare professionals there. So even though it's supported by doctors and nurses, so long as they can have fun, they would be prepared to go there. So we share the rationale behind that, and it provided a lot of food for thought for us. But then as far as Hong Kong is concerned, in terms of manpower, we might not have been able to do what they have been doing. But then in preparing our report, we are not just looking at the situation in Hong Kong. We look at their strengths and experience. We would be prepared to invite them to come along. And when we set up this permanent committee, we would be learning from them and their strengths. So thank you. Next, Leung Yu Chung. Thank you, Chairman. Just now, many deputations have looked at the issue from different perspectives, and they also share with us the needs. And in the administration's reply, they also set out a dozen or so items that they have been doing. But then when you ask the Commissioner, he also made some response. Indeed, when compared to some previous responses and discussions, that response is a lot more concrete, because at least he was able to come up with some figures, and he was also referring to some improvements instead of just sharing with us what has happened in the past. Still, when it comes to improvements, it's like a drop in the ocean. So when it's at the community level, the rippling effect would be insignificant. I'm not saying that there is no effect whatsoever, but then the rippling effect is so small that you can hardly feel it. Yes, the budget has been approved, so even if there are further improvements, we will have to wait until next year.
But I really want to see that in a coming year, with a new term of government, I want to see that we have more efforts put in. Even though you say that you have already doubled the funding from 160 million to double it, but still the demand is more than doubling, and it cannot be met just by doubling the funding. And also, you mentioned the $2,000 per month. That is almost meaningless. Whether you want the families and carers want the $2,000, of course they do. But does it help? Hardly. And you mentioned just now that there is a very limited quota, and you said that you want to extend that quota. I see that you already know where the problems are. But the thing is, you really cannot resolve the problem because the demand is just too great compared to what you're offering. So the Secretariat, I would want you to be able to list it out, all that was mentioned just now by the deputations, and also the list as mentioned by the chairman concerning targets, future indices, as a gauge for effectiveness. Because only with indices can we continue to monitor and also to gauge whether it is effective. I mean, it was mentioned just now that there's doubling of funding, and as I have mentioned, it's just a small ripples in the huge sea. So I would like the Secretariat to do that. And also the government should tell us for this year, for instance, even if it's double the funding. Whether this is what about the interim? What about the long term? We want to see a longer term planning. Let it not be so stopgap. What does the government want to do in the longer term? For example, I find it quite a shame in terms of human resources, manpower. The government said that they have already 300, 400 doctors graduating. That sounds so good, but in fact with retirement and also attrition, there is actually no net addition. So mentioning one part of the fact and not the full fact is meaningless. Of course, with more manpower, we'll be able to do a lot more, but the reality is we don't have the manpower. So what do? Do we stop short of providing more service? What we want is real growth and real additional services. Mr. Sun, you have anything to respond to? Any response to the point made about manpower? Well, in the past few years, we have been facing with a shortage of manpower in medical and health, apart from mental health. And we at the department have been doing the following, and it will be announced pretty soon. And that is in terms of planning and professional training and development of medical and health staff, which will be announced in June. And nurses, medical doctors, occupational therapists, physiotherapists, dentists, and all those which are supervised and regulated under the law. We want there to be long-term planning. We want this long-term planning to give us an idea as to whether there is a shortage in the near future or what. We want there to be planning and solutions. There's a lot of challenges that doctors face, but the main source of medical doctors is local. It takes 6 years for the medical doctors, undergraduates to graduate. We are already extending the number of medical students to 420, and at the UGC, it had already added the latest number is 470, actually, for the local university-trained medical officers. And this is not just for the mentally ill, but also for the entire medical field. We want there to be more resources to alleviate the pressure. A lot of doctors have come to retirement age, and at HA we want to retain these retiring medical doctors so that they can stay on for a period of time in the hospitals of the HA. So this is a multi-pronged approach. We want to be able to maximize the resources we have on hand, human resources. But still, it takes a long time. 420 graduates is but generalists graduating this year, and training specialists will take another 6 to 7 years. So even with this 100 doctors, if they all become psychiatrists, it takes another 6 to 7 years in order to train them up. So, indeed. So, we have heard and summarized the views of those coming to the meeting to raise their points, and also the Labor and Welfare Bureau and the Social Welfare Department in the HA will have responded to some of the points. Leung Kwok-hong. Right. Natural attrition and retirement of medical doctors, the ratio of that to new graduates or new entrants into the profession. You mentioned just now that there are more new entrants, but what is the net loss? I think there should be some explanation. I have friends whose children are mentally ill, and I have to go around looking for psychiatrists for them or clinical psychologists for them. And it's very expensive. And what kind of service can they get from within the system? Some of the relevant medical officers actually get out of the system because it's more lucrative being in private practice. Give us some figures there. And another point, as the chairman had mentioned, it takes a lot of time training up these specialists and do provide funding. Now, you talked about peer support. Peer support, these are paid positions. This is different from the carers. As for the carers, they get only $2,000 a month. What to do with that? I mean, if you have already told us at the Let Show here that there is a shortfall in terms of manpower, then please, you should look for solutions to alleviate the pain. Do you have that up your sleeve? Do you have plans? Peer support and carers, yes, those have been mentioned by those who have come up today, and also social workers and other welfare support workers, night service as well. Night service been repeated time and time again. Perhaps you should really go back and do something there. The demand there is very real. You have to approach it from the patient's point of view. Taking leave for medical consultation may end up the person losing his or her job. And if they come to you, you're not able to find a new job for the person. And what to do? This is a very basic demand, really. Now, if you cannot provide night service in all the districts, perhaps in one or two of the sites, and not everybody needs night service, of course. You're so stubborn. Tell us the figures, and that's meaningless. Insufficient doctors, you say, and you require and you request for night service. Well, it just cannot be supplied, that kind of service. But we need to be user-friendly. These are ex-mentally ill persons. They need the service. And also halfway houses, sheltered workshops. These are breaking at the seams. We have more people seeking this kind of service, and there are services. Now, shortfall of nurses and medical officers, I can understand that. The others can be provided by just funding, money alone. Why don't you do that? You alleviate the pains of these people, and also you alleviate the pressure of the nurses and the medical officers. Are there such plans, Mr. Chair? As you have mentioned just now, 3, 5, 7 years will not suffice to resolve the shortfall in medical officers. What other plans have you, Mrs. Sin? I don't have the exact figures concerning medical officers or doctors. I will supply that after the meeting. As for the need of the mentally ill, nurses, doctors, support, and peer support, they all fill different roles. Of course, Dr. Tang can explain further, but peer support is different from medical doctor service. And we've been talking about this, and that is within our constraints of resources, can we do the best we can? Peer support service is something that we've been trying out a couple of years back. At first, in very limited area, and it was found to be positive and effective, and we have then extended it. And in providing peers, we have to be selective as well. The person will have to find the work fulfilling and satisfying, and the person has to be appropriate for the service as well. And also for medical officers training, for example, nurses, there have been more nurses trained for the light cases of mental illness in Kowloon West, for instance. They are actually they actually get service from the nurses first and the clinical psychologists first, so that they get the service early on before they actually see the psychiatrists. I know the HA had been trying their best within the constraints of existing resources. I mean, Mr. Chair, if he didn't say so much, I wouldn't be saying this as well. I mean, some of the people are not seeking consultation because they fear labeling. So in a sense, they are already helping you to alleviate pressure. But the thing is, are you providing the service? And these patients fear being labeled, and they do not come forward for to get service. And the depositions have already told you that the young people and students and also parents, these are the suffering group, and they do not come out until they have clear symptoms of mental illness. And you're saying that there are specialist teams. Can there be more of such teams? And I've repeated this many times because you have mistaken the demand, and therefore there is a shortfall of service supply. I fully remember this. I remember at Tung Chee-hwa's time, it was said that they will stop training nurses. I remember at the time that I objected to this. At the QE hospital, etc., these nurse training courses were closed. So this is helping you alleviating the work pressure of the doctors' work pressure as well. Now, Mr. Leung was talking about the manpower supply. In June, you will be announcing the planning for long-term manpower supply. But in the interim years, there is a long queue, especially for the students and the young, 2 years or more, depending on the district. And in this interim, before your trained personnel come to the market, and given the dire undersupply of support and services, what to do in the interim? Looking at figures, it is true that in the past period of time, there had been increase of cases and young people seeking help. Mr. Chair, please, social workers are insufficient, and there is so much funding for combating drug abuse among the young. I mean, if we can serve them early, if we can nip the problems in the bud, it will help so much more, because these are not mental illnesses among the young people as such, but they need social welfare officer support, social worker support. They are emotionally disturbed. I mean, this is an integrated government support, isn't it? Mr. Chair, and also we have these pilot schemes, and that is
we share the sentiments of the teachers. So we identify a dozen or so secondary schools, and we work hand in hand with them. So we do have healthcare staff to provide support to them, so that at schools where they have identified students with psychiatric problems, we will try to provide support for them. So we will try to assess the effectiveness of this program. So we have already started that. So we started that with this school term. So this is the mode of operation. So we took the initiative to go into the schools, and then we use the schools as the venue in providing the service. And then when we are able to set up the permanent committee, then we'll be following up on the recommendation of the report on support for the young people. So we'll be taking follow-up action accordingly. Well, because of the time constraint, I have to exercise my power to extend the meeting by 15 minutes if you do not object, right? Okay, but Deputy Chairman. I'd like to make a request, and I'd like to remind you of something. All right, today we're discussing this subject, but then earlier on at this health services panel, we already discussed that, and a motion was moved, asking that for the permanent committee to be set up, we have to have a number of service users and also parents group to be involved. And I was asking that at least 1/4 of the membership should be from those stakeholders. All right, they promised that, but then they would be taking up a very small share, so only 1 or 2. And then at the subcommittee level, there will be none at all. All right, you have done that already. And then you're going to set up this permanent advisory committee. So my view is that I would express my support for that, but then I would also at the same time express my disappointment, because we hope that it's not going to be just an advisory committee. We hope that that could become a coordinating committee, but then you're not going to do it. All right, the motion has been carried. And then for the deputations that were there, many of the mutual help groups and the parents groups were prepared to take part in such consultation work so that they can work together with you. So I hope that when you set up the committee, you will not just be having 1 or 2 members from those groups. At least 1/4 of the membership should be from those groups. That's the motion that has been carried. All right, you talk about the service demands and so on. I'm not going to repeat that, but then I'd like you to seriously consider the following. All right, take care of the family members, because they are really very disadvantaged. All right, if you look at the press reports today, well, from age 15, the person had to take care of the parents who have been mentally ill, and she's been doing that for 20, 30, 40 years. All right, you can imagine. All right, she was only 10 years old, and already she was required to take care of her parents who were mentally disturbed. All right, she has lost her childhood altogether because of the need to take care of her parents. And we understand that it's a very difficult task. It's a very frustrating task. Well, both you and I would have a chance to take care of others. We all know that it's very difficult. Okay, so for the 400 odd people with SMIs, well, we're talking about 40,000 plus such people with SMIs. So what about their family members? All right, their children might have grown up, so they might have gone through that difficult period already. We simply have no idea as to how serious the problem is. All right, how many of them are under 16 or under 18? So how many family members are the main carers, and yet they are underage? They are under the age of 16 or 18. And what is their condition? Chairman, I even think that this is something that the Children's Rights Subcommittee should be concerned about. Well, even if the number is not significant, it's like children who are stuck at the hospitals. So should we be concerned about them? Because if we do not pay attention to them, then they could easily be ignored. I'm not asking about the figures. Well, you should be trying your best to take care of them. But then what about the underage family members? All right, they are only in their teens, and yet they have to take care of their parents who are mentally disturbed. So it's hard to imagine how difficult their life might be. All right, Dr. Sun, any response from you about the advisory committee, about the membership of the committee? So what about the users and also family members, and also what about the number of underage family members? Thank you, Chairman. Thank you, Deputy Chairman. Last week, at the Health Services panel meeting, there was a motion that was carried, and the motion was very clearly worded, asking the government, in setting up the permanent advisory committee, we have to ensure that patients groups and family members are properly represented. So at least 1/4 of them should have come from these groups. So we are very clear about that. And while we are considering how the committee should be set up, we will definitely bear in mind the wording of the motion. With regard to underage family members, we don't have the figures with us now. But then in undertaking the review, we did have family members represented on the review committee. But then during the past 3 years or so, during our discussion, if my memory or recollection serves me right, very rarely was a subject being brought up. So very rarely have we heard about underage family members having to take care of their mentally disturbed parents. If we are aware of that, we'll try to find out what the situation is like, and the mutual aid groups might have more figures. Yes, Oi Kwan mentioned that they had been working with the University of Hong Kong on a joint study, so you may want to approach them for more details. I'd also like to open the floor to deputations with regard to the government's response and also the discussion just now. Anything that you'd like to say? If yes, then I can give you each a minute. Yes? 3, 4 would like to speak. Okay, first, Mr. Y. Well, actually, Caritas has already applied to Community Chest for a 3-year program, so that there would be this companion program, so that for children between the age of 5 and 18, they can be supported. In fact, for children of the mentally ill, they are also having a hard time, so the community chest would only be able to support them for 3 years. Now, turning to the Caritas difficulty in hiring venue, all right, the community hall would only inform them a week in advance that they would not be able to get a venue, because Caritas only have a temporary office accommodation. Well, for the young people at Caritas, I also hope that the HA would also pay more attention to their staff, because whenever I go for follow-up consultation, they would say that if you are ill, you have to inform your boss. But then if they really inform their boss, then they would be under stress. Because in the past, HA staff who are not entitled to healthcare benefits, I hope that you would give them this benefit. Thank you. Yes? Just now, I heard Dr. Tang from the HA who said that you're also suffering from a shortage of doctors. I understand that because I've been going to the HA for consultation for many years. I fully understand that. But then in recent years, my young daughter has also been diagnosed with this illness. Now she's in her 20s. And during the past year or so, through some healthcare professionals, I understand that at the Kowloon Hospital, well, there is a night outpatient service, and there's a program. And I attempted to bring my daughter to seek outpatient consultation, and I told my husband that I just went there for consultation. The reason why I took my daughter there was because according to the information that I got hold of, I could take my kid there, and then very expeditiously she would be able to get in touch with some psychiatric nurse or doctor. She might not be eligible for psychiatric consultation, but then still they would be able to prescribe medication for my daughter. Okay, so my daughter did seek consultation. So she went to the night service for consultation, and then she was asked to register again. And then 2 or 3 days later, she was able to see a doctor, and then that doctor, well, on the first occasion, well, if he were not a doctor, then he would not have been able to prescribe medication. And then within a month or so, she went to see a doctor again, and then the doctor did prescribe psychiatric drugs to her, and she is now on that medication. I don't know how come this was not made public. How come we were not aware of that at all? So I was only informed by my doctor, because my daughter already had very serious problems, and she's not able to graduate in her final year, and she suspended school for a year, and now she is studying for her final year. Well, I was trying my very best to seek help for my kid, and she's in her early 20s. All right. Next, Lam Sin Man. Well, we are of the view that prevention is better than cure. We really hope that the Hong Kong government can come up with ways to enhance awareness within the community. This is not something for a minority group. We have heard that for the patients and their family members, they are very disturbed. In particular, at the family level, they are struggling within the family. Nobody is there to provide support, and they have to be on call round the clock to take care of their family members, and as a result, some 40% of them also have emotional problems. All right, you talk about a shortage of manpower. Well, the hospitals or the HA should have looked at how you can outsource your work. If we have manpower problem, then we would try to seek external help. So how come patients are not supported at all? How come there is no external support at all? So you've taken more than 10 years to train up a doctor. What about those who are in private practice? What about psychiatrists who are in private practice? Why can't you seek their help in order to ease the pressure on the HA? Why have you not thought about that? Thank you, Ms. Lam Sin Man. Next, Ms. Lau Sao King. Thank you, Chairman. Thank you for giving me the chance to speak. Well, I've heard the directors say this. Well, psychiatrists are suffering from a manpower shortage. We understand that because to train up a psychiatrist would take a long time. But then have you ever thought about this? That is from overseas countries. Why can't you attract more psychiatrists to come back to Hong Kong to work? I think that would help ease the pressure. I understand that many experienced psychiatrists have left the HA, and one of the main reasons is, of course, they're able to make a lot of money in private practice. But what about your remuneration to them? Can it be made more attractive so that they can work part-time for the HA? That would also go a long way in easing the pressure on the psychiatrists. All right, by working part-time, you can just be working 2 or 3 days a week. All right, I understand that many psychiatrists have gone into private practice. Okay, because of the time constraint, Mr. Sun, can you be brief in your response? Yes, I'll say a few words and then I'll ask Dr. Yu or Dr. Tang to respond. Well, I didn't go into the details just now. Well, other than locally trained psychiatrists, indeed, under the medical registration ordinance, well, through limited registration, we can recruit overseas trained doctors to come back to Hong Kong and work for the HA. Well, in fact, at the 2 previous meetings, the Director of Bureau said that we'd like to amend the medical registration ordinance, and one of the purposes is to shorten the approval period so that it can be extended to 3 years from the current 1 year, so that for the limited registration, the validity period can be extended. That would increase the attractiveness to overseas qualified specialists and doctors to come back to work in Hong Kong. So other than relying on locally trained doctors, where necessary, we are also prepared to make use of overseas talents. Ms. Tam also referred to the situation at Kowloon Hospital. I'll defer to the 2 doctors to explain. Yes, Dr. Yu? Well, just now, Ms. Tam referred to the outpatient service. I suspect that, at the general outpatient clinic, that's the integrated mental wellness clinic, we also have family doctors there who can look at the more simple cases, for example, those who are suffering from insomnia and those who are mentally disturbed. I suspect that your daughter might have received that service. And then for doctors working part-time, indeed, the HA has been hiring part-time doctors in order to help make up for the shortfall in the level of service. That would also include psychiatric service.
討論到呢度，我都要做個總結㗎啦。雖然啱啱出咗呢。
Now I have to summarize. Even though the review report had just been completed and we have discussed that at the panel, but we are here mainly talking about the community support services for the mentally ill. Now, where can they stay in the community? This is a problem already because shelter and halfway houses resources are limited, and also support for the carers and families very important. There is a shortage, a clear shortage of medical officer support, and it has been so for a long time, and starting from 2012 or even earlier when we talked about having more medical doctors and nurses to help. It's really taking a long time, and it does take a long time for the training of such professionals. And in the interim, we need solutions to support the family, the community support for the mentally or ex-mentally ill persons are important. And for the higher risks, for example, those with very young family member carers, or those who are seriously mentally ill but who are singletons and who live alone, all these are indications of high risk. However, there is no support for these sectors. As for carers and peers and family support, perhaps that can be provided through other services. This may not need medical persons such as nurses and doctors going up to the residence of the ill persons. Now, it was mentioned that peer support is good, but we're talking about just a few dozens available in Hong Kong, these peers as supporters. And we have to wait a few more years for there to be, more of such service. And also these 2,000 spaces are means tested, and also this extends to other disabled persons as well, their carers as well. But it seems that there are a lot of services, but they are all deficient in terms of quantity and in terms of timeliness. I know that we're all very concerned about this, all of us here. And night service also is another one. The HA seems to be considering the management needs on the part of the HA rather than the needs of the patients. There's been a shortage of staff for so many years, and the demand had always been there. And given that, we should provide some flexibility in arrangement. But through these years, nothing's been done. So when we talk about the needs and the demands, we put all of the requests on record, and the Secretariat will give us a summary and a list, and the administration will have to respond to the items one by one on the list. As for the next term of government, we want this regularized consultation committee. We want it to consider all our views, but I worry that this is consultative only. It has no planning vision. It is just a platform, and it perhaps can even only be superficial. We don't know, but we do hope that it is for real. And in the next term of government, that there is comprehensive planning. And apparently, we will agree to your report. And that is, without mental health, there is no health. This is good as a slogan, but for us to really face up to the problem in Hong Kong regarding mentally ill, it still takes time and more efforts. Well, I want to thank those of you who have come up for your sharing, and we will be looking further into this topic. It was mentioned just now that there are special groups that we need to look into to support. For example, young family members take as carers. Yes, we will follow up with that as we go along.